Well, tonight's presentation is entitled Diagnosis and Treatment of Pulpal versus Periodontal Disease. Our featured presenters are Drs. Rico Short and Dr. Roy Brooks. Dr. Short became a board-certified endodontist in 2009. His private practice, Apex Endodontics, is located in Smyrna, Georgia. He's also an expert consultant to the Georgia Board of Dentistry and an assistant clinical professor at the Medical College of Georgia School of Dentistry. Dr. Brooks currently serves as the dental director of the Georgia Regional Hospital in Atlanta. Now, application for CME credit has been filed with the American Academy of Family Physicians and has been approved for a maximum of 1 prescribed credit. This presentation has also been approved for 1 hour of CDE credit. Well, today's presentation will involve question and answers as you see fit. We will not take a break for questions until the very end. However, as your questions and comments arrive, feel free to type them into the Q&A box that's located at the bottom left-hand corner of your screen and click submit. And Drs. Brooks and Short will get to them as they arise. So with all of that said, let's welcome Dr. Roy Brooks and Dr. Rico Short.
Hello, I'd just like to thank everybody for joining us this evening. And I'm presenting Dr. Short. I've known Dr. Short for many, many years, professionally, socially. He is actually my endodontist. I have had great work, great experience, no problem. He's a great clinician, has a friendly staff. He's actually worked on my daughter and my wife. So, with no more to do, here's Dr. Rico Short.
Hello, good evening. Tonight's topic is going to be on diagnosis and treatment of pulpal versus periodontal disease. So I want to thank Dr. Brooks for inviting me out and to spend some time and share some knowledge with everybody who's logged in with this great organization. So we're just going to jump right on in here. And I do have to mention this disclaimer. The information presented in this presentation is designed for educational purposes only. The reproduction and or selling this material is unauthorized unless approved by Dr. Rico D. Short and or the American Association of Endodontists. I can be reached and my email is dr.short@yahoo.com, or you can reach the American Association of Endodontists at www.aae.org. So tonight, as I mentioned before, the topic is going to be on diagnosis and treatment of pulpal versus periodontal disease. These are some objectives that we're going to cover tonight and fulfill. First, we're going to define and diagnose the pulpal and periapical status of teeth. We're going to establish the difference between pulpal disease and periodontal disease from an endodontic perspective. And also when to treat endodontically versus periodontally. And we're also going to talk about some of the techniques on how we treat some cases endodontically as well. My practice, the name of my practice is called Apex Endodontics. We're located in Smyrna, Georgia. God's country is what I call it, God's side of Atlanta. And my slogan is getting to the root of your problem. And that's what we want to do, not only in my office, but my dream, my goal is for all the dentists when they have patients that come in the door is get to the root of their problem, take care of their problems, and take care of their issues, especially if they have pain. My office number is 678-503-0790. Again, my email address is dr.short@yahoo.com. So let's jump right on in. Which one is the most important for diagnosis? The dental pulp, which consists of the nerve, blood vessels, or the periapical attachment, ligament, or bone? So I'm going to let you just ponder that. Which one do you think is most important for diagnosis? After a few seconds of thinking, hopefully, you've said both, because that's the answer. Both are very important for diagnosing a case. The dental pulp, this is a small mass of loose connective tissue, blood vessels, and nerves, and is located in the chamber within the dentin layer of the tooth, and that's here. Also, the periodontal attachment. That's the supporting structures of the tooth that include the periodontal ligament, the alveolar bone, the cementum, and the gingiva. So this is the relationship. A healthy periodontal tissue provides nourishment and support for a tooth roots, but unhealthy pulpal tissue or an infected pulpal space can contribute to the loss of periodontal attachment. So there is a relationship between the two. So let's just jump right in. I know most of uh, some of my colleagues, when we just jump right into cases, that gets them all revved up and excited. So we're going to jump in. Look at this, a lower second molar. So this patient came to my office complaining of pain, and we see this radiolucent area. What do you think this is? Actually, I'm going to help you out. This patient actually, I got some history on them. They said they were in the military and they actually had a supernumerary tooth in that position. They had to go to an oral surgeon, get that tooth taken out. So what you're seeing here, this is the crown of a tooth, of a supernumerary tooth, and this is the root. And what happened is when they took that tooth out, they actually devitalized this premolar. So when we did pulp testing, which what we're going to talk about, which we used cold in this case, it was non-vital and it didn't respond. And also it had some resorption going on. So in a sense, this was a pulpal issue as well as a periodontal attachment issue because it did affect the bone, cementum, and the ligament here. So this is a case that I treated. We decide to, what are we going to do? And I just kind of told you the diagnosis already, so I'm helping you guys out a little bit by letting the cat out the bag. We're going to talk about prognosis and what do we do? Do we retreat? Do we extract? Or do we do a surgery on this tooth, which is an apical? Let you guys kind of ponder that a little bit. Well, as endodontists, of course, we're going to try the retreatment because we want to try to see if we can save the tooth. So after we talk to the patient, this is just showing when we accessed the tooth, we opened it up, we cleaned it out, we got our length, and you can see there's a resorptive defect right here in this apical third. So what we did, we placed calcium hydroxide, which is an intracanal medicament that endodontists really like, and we actually fill the chamber. Now you see this little squiggly line here? What do you think that is? This is actually, believe it or not, a little small piece of separated instrument. When we were actually originally going to find the original canal, a little piece of the foul broke off in the tooth. Guess what? Will that cause problems? Not really. Long as that foul is sterile, it really won't cause an issue. In fact, what you have to do is let the patient know that that happened in the tooth, and you reassure them that most of the time that doesn't affect the success rate. So I didn't want to go in here and try to dig this thing out and create a bigger issue. So we told the patient about it and we would just fill it with the filling material and it should be fine. So this is what we did. So once we opened the tooth up, we actually filled that material in with MTA, which if you guys never heard of that, endodontist, that's our miracle material. It's actually like a modified Portland cement agent that we use to seal up perforations and also resorptive defects. And from here on up, we use gutta percha. So this case, we've been tracking this case, and so far this patient is doing well. So this is a pre-op, and this is a case when it was actually restored with the temporary crown 2 years later, showing we have some healing. So this patient is very happy they didn't have that tooth pulled. This patient is very happy that they didn't have to do any type of periodontal work regarding this case. While pulp vitality may not often be affected by periodontal disease, evidence exists that periodontal disease can actually affect the health of the pulp. How do you think that? How can periodontal disease affect the health of the pulp? Let's take a look at this case. This is tooth number 8. No, I didn't do the root canal. This root canal was done by a general dentist, and they didn't really get it all the way down to the end of the root, didn't do a great job in cleaning and shaping, and they didn't get a good job in a good obturation. So we actually retreated the case. And once we retreated the case, look at this thing right here. What do you think that is? Let me help you. It's a lateral canal. So what happens is you can have these little lateral canals or portals of exit that can actually affect the dental pulp if you have periodontal disease. And that bacteria can actually go right inside there and cause the pulp to become necrotic in some cases. So an important rule of thumb, very, very important, very, very important. I'm going to repeat one more time, very, very important. A healthy pulp rules out endodontic treatment. If that pulp is healthy, after you do adequate pulp testing, do not do the root canal. And we're going to show you some cases on why. This is a case, the patient came in, teeth number 24 and 25. The general dentist was very concerned about this area. You can see the radiolucencies down here, okay? Now, when we see those radiolucencies, does that mean we just automatically start doing the root canal? Dr. Brooks, does that mean we automatically start doing the root canal? No, okay? Because we have to take this through a battery of tests. So what kind of test are we going to do? Pulpal and periodontal testing. Let's talk about some of those tools and techniques. By the way, let's go back to the previous slide. I'm just going to give you guys a hint. We pulp tested these teeth to cold. The patient said they felt cold evenly on all those teeth. We did percussion sensitivity, no problems. This was a middle-aged black female. So if you can remember all the way back to dental school, this is very pathognomonic for what we call periapical segmental dysplasia, or cementoma, some people call it. And there is nothing that we do. There's no need to treat. Sometimes these things may actually become radiolucent. They may actually go back to radiopaque. And we'll talk a little bit more about that in the lecture. So how do we pulp test these teeth? And also we do periodontal testing as endodontists. Let's talk about pulpal. How do we test pulpal? We use temperature. My favorite is cold, endo ice. If you can't get a really good reaction from endo ice, sometimes you can use heat. You can use warm water. You can heat up the gutta percha, especially if the case is necrotic. Heat will actually cause that patient to get sensitive. You can use the electric pulp tester. No, this is not early pregnancy test. This is electric pulp tester, and I'll show you guys what that looks like. Periapical. We can do some periapical. We use periapical testing, and these are some of the tools we use. Percussion, and these asterisks mean this is the most common that most endodontists use. Palpation, and also biting. Bite test is really good when you're kind of clued in and maybe cracked tooth or dealing with cracked tooth syndrome. We use a tooth sleuth for that. And here are some pictures of some of the things we use. This is the endo ice. This is the endo ice that I like to use, and I like to actually spray it directly on a cotton ball instead of a Q-tip. Sometimes when you spray it on a Q-tip, the wood can actually absorb some of the cold, so you don't get as accurate, consistent testing with that. This represents palpation, periodontal probing, the mirror, and this is one version of electric pulp tester, and this is our famous tooth sleuth here. And the mirror, actually, I use the back of the mirror to do some percussion testing. Let's talk about classification of disease. We got two different classifications of disease. We're going to talk about pulpal first. We got a normal pulp. Basically, you put cold on it, they feel cold, and it goes away within 5 seconds. The pulp is normal. Secondly, previously treated. In other words, if the tooth has already had a root canal on it, the pulpal status would be previously treated. Reversible pulpitis, recent restoration, recent filling. Sometimes those can be sensitive for a while, and the sensitivity just goes away on its own. Irreversible pulpitis means that you put cold on it, it does not go away. It
Dr.
lingers.
Short,
Patients hold their face,
with
they
the
hit the roof, got
restoration
to pull them off the
presently in a
ceiling.
tooth, does the cold
Yes, sir.
testing, is that affected by filling, or what? What do you have to look for on a tooth that doesn't have a filling opposed to one that has a filling? And with electronic pulp testing?
That's a great question. Basically, the depth of some of the fillings actually conducts temperature more, and the larger fillings, especially amalgams versus composites, typically a lot of amalgams will conduct more temperature sensitivity. Also, if you have crowns, you have to be very careful because you can't use electric pulp testing on a tooth with the crown because you have to actually touch the actual tooth itself. So with crowns, you're kind of limited to basically temperature when you're dealing with this. And sometimes with crowns, you may not get that strong response because the crown itself can insulate, the nerve status. So this is where you have to really be selective and you have to use some of these other testing as well as the temperature sensitivity. You may have to use a cold bath. You can isolate the tooth with the rubber dam or warm bath. So there are certain considerations when we have restorations in place that determine
Yes,
if we
yes.
get accurate pulp testing or not. Um, did I answer that question, Dr. Brooks? Okay, thank you. So we have irreversible pulpitis. We have symptomatic versus asymptomatic. Have you ever had those cases where patients had deep decay and it's close to the pulp and they're not in pain? And you're like, I don't understand that. Why aren't you in pain? Those are chronic conditions, meaning that it's kind of, I equate, look at that as kind of like having the ant bed, the big giant ant bed. As long as you don't touch it, it'll be okay. But if you just tip the top of that ant bed, those things will come out running. And that's kind of like what these kind of cases are. As long as you leave it alone, it'll probably be okay. But as soon as anything touches it and started to going, man, those patients usually going to be in a lot of pain at that point. And also, you got necrotic cases, the necrotic classification of disease with the nerve. So, from a periapical standpoint, so for endodontic diagnosis, there are two types. There's pulpal and there's periapical. Periapical normal means you tap on the tooth, patient doesn't have any issues, the ligament looks great, no broken lamina dura. You have acute apical periodontitis, pain and percussion. You tap on that tooth and they want to lift off the chair. And sometimes this is with or without a lesion on it. Chronic apical periodontitis. These are lesions present with no pain. It's similar to the asymptomatic irreversible pulpitis. So you have a lesion there. You say, how long that's been there, Miss Jones? Oh, it's been there. I don't know. It's been there for 10 years and they don't have any pain. Don't mean they don't have a problem yet. So eventually those can turn into acute apical abscesses and they just wake up one day and they're swollen. So those are the classifications from a periapical standpoint. Oh, and one more. Chronic apical abscess. Basically, the patient is usually not in pain, but there's a little sinus tract and it's draining purulent discharge and all that. And usually these patients are asymptomatic because that pressure is being relieved through that sinus tract. So accurate diagnosis is key. In endodontics especially, if you don't have an accurate diagnosis, I recommend do not do the root canal. I had a case today, a patient came in and she took some Motrin 800 right before she got ready to sit down in my chair and thought she was going to get a root canal. Well, she took the Motrin 800 and she was out of pain. The x-ray didn't show anything. So I told her she has to come back when she doesn't have the pain medicine on board because that masked where the issues were. So pulp testing wise, everything responded with the normal limits because she just took the Motrin 800 like an hour before she came to my office. So radiographs alone do not provide enough information to make a correct diagnosis. I can't tell you the number of colleagues I have. They say, Dr. Short, let me send you this x-ray. Or people that I know that practice dentistry in all of the parts of the world from Afghanistan to Pakistan to Australia, they'll send me an x-ray and they say, what do you think is going on? I cannot give them a 100 foolproof answer because the patient isn't in my chair. So I'm limited to an x-ray. So you cannot make an accurate diagnosis based on the x-ray. So I give them some information, but I tell them without having the patient here or without at least you doing these pulp testing and let me know what the data is like and I can corroborate that with the x-ray, I can't give you an accurate diagnosis. So we want to always use the periodontal probe and like I said before, all necessary endodontic diagnostic tests that we talked about in order to see exactly what's going on before we can recommend any treatment. talk about pulpal and periodontal lesions. Lesions fall into one of three categories based on their etiology. They're going to be pulpal lesions, periodontal lesions, or combined lesions. Pulpal lesions. These are strictly pulpal in origin, and they actually resolve with endodontic treatment alone. And we're going to show you a few of those cases. This is example. This is a mandibular first molar with a large periodicular lesion extended into the furcation here. There is some deep probing, but you notice it's a narrow base probing, and it's actually through a sinus tract that exited through the sulcus. Yes, you can have draining sinus tracts right next to the tooth, and you can actually probe that. Now, there's another thing you want to really look for too when you get some probing. You want to also make sure that you're not dealing with a crack, but those are usually more wide-based probing. So this is following the root canal therapy. And then 9-month recall, there was no probing into the sulcus. So this is with no periodontal intervention, no laying a flap, no cleaning it out, no putting a, what do you call those things, perio chips or whatever they call it. It's been a long time since I was a general dentist, but I know they used to have some chips you just slide past there, and you hope and pray that magically takes care of that pocket. So I don't know if you guys are still using that or not, but with these cases, the endo will take care of that. So this is a 9-month radiograph that shows a favorable response to treatment. But we usually like to follow these patients up just to make sure there's no further breakdown. This is one of my cases here, tooth number 30 here. This is a previous root canal, and the root canal looked like it was done pretty decently. You know, you have a lesion there and right in the furcation as well. So we actually retreated this case and we placed calcium hydroxide in there. If you can look closely, you probably can see a little calcium hydroxide here. So what is that probably telling you? Probably telling you that we either got a subpulpal floor canal or some type of lateral canal. And we completed the case. So we brought the patient back in 6 months. Post-op, you can see that nice healing there. And this probably healed because just like we talked about, this probably was a lateral canal or subpulpal floor canal that was cleaned and also sealed up.
Excuse
And
me,
that's why
Dr.
we got some
Short.
great
Will that
healing there. And
healing
this is with no
continue
periodontal
in
intervention.
18 months? Will you come back and see nothing there?
Yes, sir.
Yeah.
Yes, that healing should continue. Once we actually remove the etiology of the infection, the body it's already pre-programmed to heal. So once we take care of the problem, the body just does its natural thing. It just heals. So that's a great question. Thanks, Dr. Brooks, for that. Now let's talk about periodontal lesions. These are strictly periodontal in origin, and these will only resolve with periodontal intervention. Look at this vertical pocket on the mesial of the mandibular molar. We pulp test it. It's vital. Patients feel cold, don't go away. We don't go in there and do endo on this tooth because we go and do endo. This is not going to affect this. First of all, it doesn't need endo because the pulp testing was vital within normal limits. So on this particular case, this particular person need to go to the periodontist, or there are some skilled general dentists out there that can also do this kind of work. They have perio surgery and some bone grafting, and we started getting some regeneration 1 year, and the tooth still responds normal to pulp testing. Even though that very big, deep amalgam, you would think that maybe that tooth is becoming necrotic, but it's not. So we don't do any endo on that tooth. So let's talk about combined lesions. These are lesions, can be primary pulpal lesions with secondary perio involvement. They can also be primary perio lesions with secondary pulpal involvement. These aren't very common. Just like some wild turkeys hanging out in my backyard. It would be nice if they were hanging out there around Thanksgiving so I don't have to go to the store. I can get me a nice Thanksgiving feast in the backyard. So not very common. Let's talk about some combined lesions. Primary pulpal, secondary periodontal combined lesions. So this is a preoperative radiograph of this canine here. Root canal was done, looks pretty good. So the periodontist saw the patient. When they reflected the flap, they saw a complete dehiscence of the bone was noted. So they actually did root planing. This is after the endo was done. Endo looks good. They did root planing. Look at this, 4 months later, the periodontist noted the probing depths were only 3 millimeters. So we went back into the area, saw that that bone was filled in, and everything looked pretty good there. So second, combined lesions number two, primary periodontal, and secondary pulpal combined lesion. Remember we talked about those lateral canals before? That's how that bacteria can get through those lateral canals and affect or infect the pulp. So basically, we knew that this patient needed an endo, so we were like, well, looks like you may have a periodontal component as well with this. So the endo was done after 3 months post-op, after completion of the root canal and a bone grafting procedure by the periodontist. Periapical healing is progressing, and gingival tissues, they were actually pretty healthy. After 1 year, the periapical lesion continued to improve. The distal periodontal defect still appeared to be doing well. The tooth probe within normal limits and the gingival tissue looked good. This is 2 years after the surgery. The periodical lesion had healed while the periodontal defect remained virtually unchanged. So this is a case where endo was necessary as well as periodontal intervention as well.
Yeah. Yeah.
So this case walks into your office. Dr. Brooks, if you
I would
saw this
send it to the
case,
endodontist.
would you try to treat this
Yeah.
case or would you send it to the endodontist? Smart man. Hopefully, if this falls into your office, um, if you're a general dentist, this would be a great case to refer. And I'm going to show you why. This case was non-vital. Patient did have a sinus tract,
Mm-hmm.
and you see this big defect here? That's a huge defect in the furcation. So we told the patient that we're going to have to try to do some heroics here and also use our magic material, what we call MTA. So this was a necrotic pulp. Remember we talked about the pulpal status would be necrotic, and the periapical status would be chronic apical periodontitis, or some people call it an abscess because
Yeah.
it was draining, with a buccal sinus tract.
Oh,
Does
gutter
everybody know what
perch.
this is?
Yeah.
Dr.
Gutter
Brooks?
perch going in. Right.
That is the gutta percha. That's right. Tracing where that infection is coming from. So we always trace sinus tracts because sometimes you'll be fooled. We could have traced this gutta percha, the sinus tract, and it could have came out back here in this tooth. So always trace your sinus tracts. So we had to do a root canal,
Mm-hmm.
and we had to use MTA in the distal canal. And remember I was telling you MTA is our magic material, and that actually, we had to pack it all in here, and that actually packed into that defect. You see that packing into that defect? Most of the time, there are some endodontists and periodontists say, okay, now we need to send to the periodontist to lay a flap and clean that out. Not with MTA. If MTA is done properly, the bone loves the stuff, and the bone actually attaches right to that MTA, as you'll see on the next film. So we brought the patient back in 6 months. That's the pre-op. And look at that. Now this is no Photoshop. This is no camera tricks. This just shows you the amazing ability of our body to heal once you remove the etiology. So this MTA, you can see it still here, and it's always going to be here. There's a permanent material. The bone actually grew literally right next to it, showing healing. And this is without doing any type of periodontal intervention, no scaling, no root planing, or what have you. So basically, when the etiology is removed, like we said, Dr. Brooks, the potential for healing exists. Are there any questions out there so far? I don't see any popping up, so that means you guys probably already know this information, which is great. But if you have questions, let us know. So this is a case here. Uh, African American male, teeth number 14 and 15, and he was in a lot of pain. You can see there's some sweatness, some swelling and redness. Sweatness, that's a new word I just came up with. And the patient was pretty concerned about what was going on. So we took some x-rays. We pulp tested the teeth. The teeth pulp tested within normal limits. But we see, man, what's all this stuff up here? What do you think this can be up here? Could be superimposition of the sinus. This could be a rare case of periapical segmental dysplasia. That you can have those in maxillary molars is very rare. But as far as the endo pulp testing, everything went well. Would you still do endo? I think you're going to resolve this lesion. Pulp testing normal. Answer is no. This is a perio issue only. Do not do endo. So basically what you saw, that redness, he did have some subgingival calculus there. That was causing the redness. He went to his periodontist. They scaled and root planed him, and all his pain went away without doing endo. This is another case. Would you treat endodontically or periodontally? So Dr. Brooks, if you had this case here and pulp testing within normal limits
No,
and
I
you
would
see this
refer him
lesion,
to a
would you still
specialist to get another opinion.
second guess yourself and go in there and do that root canal on there? There you go. So you want to refer these cases preferably to an endodontist just to get another opinion and see what's going on. This is another case of that periapical segmental dysplasia. Pulp testing normal, and periapical testing was normal, no percussion sensitivity. Because you got to be careful, because if you treat some of these cases, they don't need to be treated, you can get in trouble with somebody's judge and somebody's attorney. And I don't think none of you guys out there have the time and want to really, deal with that. If you do, I am an expert consultant to the Georgia Board of Dentistry, and I can help you out as much as I can, legally help you out as much as I can. So let's talk a little bit about periapical segmental dysplasia, or cementoma. Basically, it's a radiographically distinctive condition which produces fibroosseous proliferations that replace bone and periodontal ligament tissues at the apex of one or more teeth. Um, though radiographic alterations are visible, clinical abnormality is seldomly seen or appreciated. Mostly black females, about 75% of the cases. Mandibular molars, multiple teeth may be involved. Stage development may be radiolucent, radiopaque, and often they're found um, without cavities. So, and teeth are vital. So you want to be very careful with those cases so you don't get tripped up. This is another case, tooth number 30. Previously treated root canal, patient in a lot of pain. Now to me, this root canal looks pretty decent. It looks like they got pretty close to the apex, but the patient was in a lot of pain. So the diagnosis would be what previously treated. That would be the pulpal diagnosis. And we tapped on the tooth. The patient literally hit the roof. That would be acute apical periodontitis. The patient was not swollen, and you don't even necessarily see a lesion. So we went into the tooth and we disassembled it. And look at this, pus going everywhere. And you're like, wow, how can he have that when the x-ray doesn't show anything? Now, statistically, what has to happen is there has to be 30% of the buccal cortical plate has to be removed before you can even see a lesion. So yes, you can have infection there, and the x-ray is absolutely normal. So these are some cases that you probably want to send out of your office. And sometimes these patients aren't crazy. Sometimes they don't just want drugs. Sometimes they do have a real problem, but you just can't diagnose it. So here's the pulpal diagnosis that I told you about, previously treated, periapical, acute apical periodontitis, or an abscess there. And you can see that is draining purulent discharge. So we retreated it. We placed calcium hydroxide for a month, and we completed the case. So this is before, this is after. So it doesn't take a rocket science to see that one of the main differences is that this is actually cleaned out a little bit more to the end of the root, and also that the filling material is a lot bolder and thicker. So there's a less chance that you have any tissue tags or anything like that. Also, I have an advantage because all my root
Now,
canals are done with a
Dr. Short,
microscope, hence
on that one
microscopic endodontics.
previously, if the gutta percha was narrower
Yes.
on the original, does that lend rise to problems if you don't clean and fill it
Yes.
enough?
Yes. If you don't clean it and shape it, that can give you problems down the road. Because again, if we don't remove the etiology, or what I call it, the critical mass of bacteria in the tooth, that you're going to still have some
Right.
issues down the road. Like I said, if I look at this endo doesn't look bad. Doesn't look bad, but to me it's very weak. So when I look at that, that lets me know that um, they possibly could have done a little bit better job in cleaning and shaping. If they would have, they probably would have gotten a result similar to the one I had, and possibly the patient wouldn't have had the
Yes,
problem.
Joshua
I
Day.
see a question
With
down here in the
exclusively
lower right
periodontal
corner. You see that,
etiology
Dr.
of
Brooks?
symptoms, will you get more response with lateral percussion versus vertical percussion casting?
Oh, okay. That's a great question. Typically, what I always do, I start off with the vertical percussion testing. And once I get vertical percussion testing, if that satisfies what I need from to make an accurate periapical status diagnosis, I'm fine. If I'm a little concerned, and then I would do lateral percussion sensitivity just as an adjunct, just to make sure that I'm covering all grounds to give the accurate diagnosis. But typically, I'll do vertical testing first. Great question, Joshua. Um, just another case, teeth 18 and 30, teeth vital, patient
Well,
was
I
swollen.
will refer again to
How
my
would you treat
endodontist.
this, Dr. Brooks?
Yeah. All right.
All
All
right,
right.
great. Dr.
Yeah,
Brooks, you're
and
on it tonight. I
Mitchell,
tell you.
is there any
All right, we
problem
have a question
associated
from
with excess calcium
Dr. Mitchell.
hydroxide beyond the apex, as apex control of the material with non-vital cases can be difficult?
That's a great question, Dr. Mitchell, and I think you are a friend of mine from a long, long time ago, because I definitely know that name. If you're out of California, you are that guy. So thank you for tuning in. Um, there is no problem with calcium hydroxide out of the apex. Now, you don't want to grossly put it out there, but in moderate amounts, it'll be fine. I mean, that's why God given us. I'm gonna take y'all back to histology a little bit. Back, he gave us macrophages, and he gave us all those things that just kind of hanging out. They're not doing anything. Let's put those macrophages to work. So when you get certain things out there, like calcium hydroxide, those macrophages will take care of that over a period of time. In fact, sometimes I like to see a little calcium hydroxide out into the lesion, because that lets me know that I got that thing cleaned out all the way down to the bottom, and just in a little bit, in the lesion kind of helps me sleep a little bit better at night. So I like to see a little out there. Um, you don't necessarily have to get calcium hydroxide out to the apex for it to be effective. According to the research, that calcium hydroxide, the way it works, one way it works is the hydroxyl ions diffuses through the dental tubules, and that's how it gets to some of the bacteria that we physically can't irrigate or instrument. So that's a great, great, great question, uh, Dr. Mitchell.
Right.
Um, so, as Dr. Brooks said, that for these teeth, he would refer to the endodontist,
Right.
and that's great. And you send it to us, we'll do our pulp testing, and if we see it's vital, the patient is swollen, we don't do endo, but we'll look very closely. You can see these little tubercles here. You see, what do you think that is on there?
I don't know, doc, but he's got.
You look
Is
real
this
close.
calculus we're looking at? Yeah. Okay.
Yes, exactly right. This
Right.
is a gross amount of subgingival calculus. So this guy actually had a periodontal abscess. That's what he had. So endo would not have helped him. Now, also, the periodontal
Hmm.
condition can directly cause pulpal changes. Remember, we talked about accessory canals and lateral canals. So that can affect it. But teeth are vital and usually um, have a normal pulp when you're dealing with these just perio only problems. So you just make sure you see them, send them to the periodontist, or you take care of them from a periodontal aspect. And then if they continue to have symptoms after that, repulp test first. And if it becomes necrotic, you can treat. And if it's vital, you just leave it alone and continue to take care of it from a periodontal aspect. This is a tricky case here. This patient was in pain. with teeth number 2 and number 3. Both were vital. And look at this. You had a draining sinus tract here
Yeah.
and was vital.
Mm-hmm.
This was one of those cases that you definitely need to really get out your office. This can be some of anything. Most of the time, when you have a vital case, you won't have a lesion. You won't have swelling. I would say 90% of the time. This was definitely against the grain. Now, how in the world, you say, Dr. Joe, how in the world can you have a vital case and you still have a draining sinus tract? I'm going to help you. If you have multiple rooted teeth, there is something called partially necrotic pulps. Very hard to diagnose. And basically, you can have vitality in one pulp and an abscess and infection in the other, and multiple rooted teeth. So this was a classic example of that. We call that partially necrotic pulp. So what was causing that lesion was a one necrotic canal, and the other 2 canals were vital. So guess which tooth it was on? Do you think it was number 2 or number 3
I
with
would go
this
for number 3.
filling? If you would have guessed, Dr. Brooks.
Yeah.
And that's what I would have did too. I would have said, because you got this filling here, it's got to be number 3. Wrong. We actually pulp tested, and also we did periapical testing with, and number 2 was a little bit more percussion sensitive. We went in there, that's exactly what we saw, partially necrotic pulp. Vital mesial buccal and distal buccal and necrotic palatal canal.
Palate.
And that actually makes sense. If you think about it, the sinus tract was on which side? The palatal. So when I opened the tooth up, that made me feel pretty good, because when I saw that palatal necrotic, that's where that sinus tract is coming from. But what kind of threw me off was the fact that it's still pulp tested vital. You probably won't see this but once a lifetime. This don't happen too often. So once we did
Looks good,
endo,
Doc.
which I
Looks
think that's a
good.
pretty decent job in endo, if I don't say so myself. I'm just kidding. That's good. Look at this. And I particularly told her, I said, don't take any antibiotics, because we want to
Yeah.
see if the body is going to do what it should do. This is no antibiotics. You see that lesion is cleared up in 2 weeks. This is just with endo.
Now, doctor,
No
those
perio, no
usually
scraping
occur
out
on
the
the
sinus
palate,
tract,
on the
none of that
root,
stuff.
upper teeth, the partial necrotic.
N-
Okay.
Normally they will occur. If you got a partially necrotic case, it's going to be usually show up on that palatal. Yeah. So this is the before and this is after. And to me, that's amazing. That's amazing to be able to see that. So here it is. The patient came, tooth number 20. My dentist wanted me to have this looked at, but it does not hurt. I've had this for almost 20 years, Dr. Short. Do I need an implant? I told you, you already got one. It just wasn't centered properly, but, and guess what? What do you think I told the
Write it
patient?
on out.
Wasn't
Leave it
having
alone.
any problems, had it for 20 years, no swelling and no nothing. You got it, Dr. Brooks. I said, you know what?
Right.
Continue to ride on this guy, you know what? And until you have problems, you leave it alone. And guess what? He was very happy, because I have some periodontists and endodontists, periodontists and oral surgeon friends. That's a nail and they the hammer. So they would have took it out and uprighted that implant or that post with an implant. So here we go. We got tooth number 18. What's going on with it? This patient was a very interesting patient. She wanted to keep all her teeth, but yet she didn't take care of hardly any. So all of a sudden, she wanted to try to keep these teeth. We tried to do endo on this one, and it was just too far gone. Interfurcation. She said she wanted to try to keep this tooth. You can see this big area of infection here, all type of resorption going on, recurrent decay. And she still wanted to keep this tooth. And I'm thinking, like, I don't think we're going to be able to keep it. She wanted to keep it. We went through everything and told her we can't guarantee it. So we actually tried to do root canal on it. And I'm just going to show you how things can heal with just root canal treatment, or may not. So we cleaned it out. We actually put calcium hydroxide in there because of resorption. And then we actually decided to put MTA in the mesial root and gutta perch in the distal root. Now you see how big that lesion is? That lesion is almost touching the inferior alveolar canal. Huge, huge. Now remember, this is going to be extracted. This is done. Um, we brought the patient back 1 year. She forgot to get it restored. Now she did get the other tooth pulled. So how many times you seen
Oh,
that,
it's your
Dr. Brooks? You
fault.
do
It's
all
your
this
fault.
work, they pay the
You
money,
did get them out of
they say, "Oh, I
pain,
forgot," and then they want to blame you for
and,
it.
and they went on, took the trip,
So
ate Christmas dinner.
you did get,
Oh,
yeah,
he's
got him
such a
out of
great guy. Till
pain.
it happens again. When that pain comes back, yeah, yeah,
That's right. That's right. So I told this lady, I said, you know what? I don't know. I said, restore it. This is 3 years she restored it. Look at this. I couldn't believe it. This thing is starting to
Mm.
heal 3 years later. Pre-op,
Yeah, yeah.
3 years later. Look at that. That's amazing. And she still has that tooth. I don't know if she ever got a crown on it, but just to see the body heal with something that, with all that stuff going on, that's just amazing. That shows us that once we take the etiology, remove the etiology, the body knows how to heal, whether it's, endo or perio. So, I'm not saying that there's no room for implants for all you implant guys. The GPs that love implants, love them. They are great. Only if you can't save the tooth. Only if the tooth can't be saved and you give
Right.
that opinion to an endodontist to try to help you make that decision. So what's the take-home message? The take-home message is a healthy pulp rules out endodontic treatment. A healthy pulp rules out endodontic treatment. And that's me, posed with one of my friends
Right.
who I had to convince that she had to have teeth in order to see me as a patient. So that was just one of the people that have to my office, come to my office. So I thank you guys for your time. I thank you guys for getting involved. This is my first webinar and hope you guys got a lot of information from it. Thanks for the questions. Feel free to check out my website. I have some of these cases actually on my website at www.apexendodontics.net. This is my phone number. You can feel free to call me. If you have any cases that you want to share with me or you get stumped and you want my opinion on it, you can actually email me the case at dr.short@yahoo.com. If you are a member of a study club or a person in one of these big dental meetings, Hinman, Chicago, New York, California, please plug my name. I'm available to give lectures um, if need be. So
Thank you,
without
Dr.
further
Short,
ado,
for that
thank you
informative
again for your
hour.
time, and you guys have a wonderful
Appreciate it
night.
very much. I've learned quite a bit. Thank you.
Thank you. Are there any questions?
Okay.
Hold on just a second. We're going to see if there are a few that come in right now.
Okay.
And Dr. Short, I have a question myself. Back to this cold testing. Years ago, I guess I finished dental school before you. They used to just put the cargo of
Yes, sir.
anesthesia in the refrigerator. Is that still adequate cold testing, or what do you use? Uh-huh.
Well, as time goes on, we get better, and it's like fine wine. The more time you get, the better we get. We found what
Okay.
works better is the I call it the endo ice or the spray ice. When you have these when you put the carpules in the freezer or you use an ice stick, what happens is that ice stick actually sometimes can melt, and it can actually melt to the adjacent teeth, and you can get kind of false readings with that. So, and then also sometimes that may not actually be cold enough to really give you an accurate response. Sometimes it has to be even colder,
Okay.
and so the ice spray or the endo ice is actually colder
Okay.
than that,
Let's see.
and that'll give you more
Mr.
consistent,
Wolf,
accurate,
in the
results with that.
case with the 1 year no healing, when do you wait and when do you opt for retreat?
Well, if you have a case, and typically 1 year is my benchmark. If I bring the patient back in a year, and if I don't see any healing, and if the initial root canal was done, then I will decide to retreat the case. Um, and after I retreat the case, I will give it enough another year to make sure everything heals up. Now I would bring them back in 6-month intervals, just to make sure they're doing okay. Now, if I do the retreatment and I bring and that patient say, you know what, this tooth is still hurting. In my opinion, it's time to take it out, possibly do an implant. Now, you can do apicals, you can do surgery. To me, if you're dealing with a very good endodontist, if the retreatment don't work, chances are the surgery won't work either. And then you are actually creating kind of like I call it an empty pocket for the patient. And they start pouring all this money into the tooth, and you have to know when to cut ties. So you have to kind of balance everything out. But the 1 year is my benchmark. So after I've seen the patient a year, and if I don't see any significant healing, then we either going to look at doing a retreatment, or if it's already a retreatment that was done, then we're looking at just taking the tooth out and doing an implant.
And
In
we
some
have another
cases, we
one
may
from
look at
Mitchell.
doing an apical.
What
Yeah,
are you
great question.
currently
Thank you,
using to remove
Rebecca,
gutter
for
perch on the retreat?
great question. Right now, what I use to remove gutta percha is typically my Gates Glidden drills. I use Gates Gliddens 4, 3, and 2, and usually I'm in the apical third at that point. And then I use some headstroms and kind of watch, wind, and pull, and just take the rest of it out. Works very efficiently. Sometimes if you have that old gutta perch and it's been there for a while, you may have to put a little chloroform in there after you use the gates, and you use that with the headstrom hand files. There are some cases though, when you get comfortable or skilled enough that you can actually use some of the rotary files to remove gutta percha. They do have rotary gutta perch removing files. So you can
Now,
use that as
now
well,
Doc, when you
but you have to be
retreat,
very
what
careful
are
with
you
that you
hoping
don't
to
transport the
accomplish?
canal. It's a great question. That's a great question. When we retreat, what we're hoping to accomplish is to remove the etiology of the infection. We actually are trying to go in there. We actually trying to find missed canals. We're trying to make sure that all the as much bacteria is out of the tooth as possible in order for the body to heal. That's our goal to do that. Now, just to let you know, just in case if you did know, there is no such thing as a 100% sterile canal. There's no way you can do that unless you put somebody's whole face in an autoclave, and that won't be good. So we can't do that, and that's why there's something called a critical mass of bacteria. And right now, we don't have the technology to know what that percentage is. And also, we're not just treating a tooth, we're treating a human being that has an immune system attached to the tooth as well. So there's very multifactorial
Okay, we have a couple more
components
questions here.
that actually
Maxwell is asking,
allows
are
the
you
body to
doing
heal.
any MTA pulpotomies on immature or mature permanent teeth?
We are doing MTA pulpotomies on teeth del- that have an immature apex. We call that apexogenesis. So basically, if you have a case, say for instance, you have a 6-year-old or 7-year-old kid that damaged number 8 to the pulp, the root is immature, is not completely formed. We want to do an MTA pulpotomy. The calcium hydroxide, dical, all that stuff, that's gone. MTA is really what's taking the place of that because MTA is considered a permanent material. It seals better than calcium hydroxide and has some of the same properties. And so we would put that right in there as you would, I don't know if you heard of sphecopotomy, where they used to use the calcium hydroxide or what have you, and we actually put your restoration directly on top of that. And what you're hoping for is that the rest of the canal and the nerve stays alive so the tooth can continue to mature. If the tooth continues to mature and the patient is still asymptomatic, you don't do anything. If the patient becomes symptomatic down the road, at least it's easier to do a root canal on a tooth with the apex that's closed versus when it's open. So yes, I do MTA pulpotomies pretty routinely when I'm dealing with immature teeth. Usually with vital teeth, if that apex is closed and they have a carious lesion or trauma, typically once that apex is closed, is you pretty much have to do full
Okay.
instrumentation
All
or
right.
a full root canal on that.
Yeah,
MTA
we have one
will really help
more.
with
In
that.
your opinion, what is the best
Thank you. Thank
obturation
you, Amy, for that
technique?
question.
What would you say about Pro System GT?
Well, that's a great question, Leah. I hope I'm pronouncing that correctly. I actually just finished doing a national presentation in Baltimore to the National Dental Association, and that was a common question. Now, you're very fortunate to have someone like me to answer this question. The reason is because I'm not affiliated with any dental company. And so I don't have any biases towards any company. I tell everybody, use what works best in your hands. There is no one technique and there's one file system that's the greatest. In fact, it's almost kind of like Nike shoes. Another one comes out every month, okay? So you have to be really careful with this marketing thing. And I've been approached by all the dental companies and they want me to speak particularly for their file, and I tell them, I cannot go out here and tell people that your file is the best because I might like your file for a month and think it sucks the next month when I have the case. So, couple of things: what works best in your hand, and also the type of case you're treating, and that dictates to me what type of file system. I use a hybrid system. I use some profiles. I use some pro tapers. Sometimes I may use some GTs with different tapers. So it really all depends. And with endo, if you're really doing it at the highest level, there's no cookie cutter method. There's no, okay, you just get this and this is going to work for everything. That's not going to happen. But what can happen is that you get your armamentarium together that's going to work best for the cases that you feel more comfortable treating and with the material that works best in your hand and what's giving you the best results. And that's what I say, you stick with that. You stick with that one technique until you master that technique. Once you have that technique mastered, and then you can kind of probably pick and choose and make something to enhance it. But I also have colleagues that kind of skip. They never can master a technique. It's kind of like you want to be the phrase the jack of all trades and master of none. You don't want to be that in endo because you will find yourself very frustrated and spending a lot of money. So that's a great question, but the answer to that, whatever works best in your hands, whatever giving you consistent, great results, use it. And if it's something that you use for about a month or so or two, and you don't like it, it sucks. You just, put it to the side, put it on eBay or something, sell it to
Absolutely.
somebody you don't like. Or I don't know. I'm not saying that, but and then you just try something else. Great question. Thanks.
Well, I think we are just about out of time. Thank you very much, Dr. Short and Dr. Brooks, for such an engaging presentation tonight. I am a clinician, but
Okay.
dentistry
Very
is
good.
not my
Thank you
thing,
for having
and I
us.
found it very interesting, so thank you.
Great, great.
And I
Thanks
would
for
like to
having us.
also say to our participants, thank you again for attending this Primary Care for All.org webinar series. I would also be remiss if I did not give a special thanks to our IT team tonight. We had one guy that was working alone, and so he fielded off lots of giants in the interim. So thank you very, very much. Please join us tomorrow for the Meet the Speaker chat with the great Doc Hollywood, Dr. Neil Schulman. He'll be speaking to us on unlocking your inner humanitarian. And then on next week, Wednesday, August 24th at 8 p.m. Eastern Time, join us again for another intriguing and free CE presentation by Dr. Corey Abear from New Orleans, Louisiana. Dr. Abear is very well known and loved among the NHSC core members. So please be sure to tune in to hear him as he speaks about implementing a public health initiative in your community. And finally, an evaluation for this webinar should be popping up momentarily in another window if you're using IE and another tab if you're using Firefox. Please take the time to complete that just to give us our feedback, as well as it is necessary for your CE and CDE credits. Again, this webinar has been made possible through a partnership, and this partnership has been funded. by the HHS, HRSA, and the Bureau of Clinician Recruitment and Services. This partnership allows PrimaryCareForAll.org to serve